So hospice is very appropriate when patients are in their last 6 months of life, and that's usually determined by a physician. Unfortunately, a lot of patients end up electing hospice in the last few weeks, last few weeks or days before their death, and so they don't really get the full benefit of hospice. So, if you have a patient or a loved one who may not be benefiting from treatment anymore, for example, or they're really not tolerating treatment, if they feel like the treatment might be more harmful than beneficial, then at that point we're really looking to try to relieve any discomfort that they may be having, any symptoms from their disease process, and really just trying to make it a more comfortable death. So hospice has really been around for a long time. Ancient civilizations, people would care for their loved ones when they were dying at home, and it's the same concept then as it is now in that we want to relieve suffering. And when it comes to relieving suffering, it's a different time for everybody, and it means different things. One of those things can be really helping the patient with pain, with problems swallowing, with problems breathing, with nausea, but at the same time we're also helping the family through this process. We never know how long somebody is going to actually live. That's not up to us, but we do know that with experience you know that death can be inevitable, and if that death is inevitable, how comfortable can we make that death for a patient? There's a lot of ways that we can relieve suffering, different medications and different methods, and the hospice team consisting of nurses and social workers and the aides, they're just amazing people, and their focus is really just trying to relieve discomfort that patients may be having. One of the biggest problems at the end of life is just being very short of breath all the time, very fatigued, and that in itself can cause anxiety. So some of the medications that we can use, including morphine and Ativan and anti-nausea medications, all those things people have different experiences with, but when it comes to hospice, I always emphasize that we're using very, very small doses, with the goal being make the patient comfortable, not to fast forward anything, not to limit their days, but really to make them as comfortable as possible. And so that if we get them to a point where they're spending time with family and they're able to interact with them, but they're comfortable, that's great. But if family is seeing them suffer just for the purpose of being able to still talk to them, most families will eventually say, we would rather they were asleep and comfortable than awake and uncomfortable, and that's the point at which we will make sure that they get enough of the medication that they need. Well, hospice is very much about the patient. The patient's in the center of all of this, but at the same time, the dying process is very foreign to most people, and so hospice nurses and social workers, bereavement help, and chaplains can help the family understand the dying process so they know what their loved one is going through. One of the more common things that we see is that a loved one won't eat at the end of life and they've lost their appetite. We help to explain that that's not a painful process, and it's just natural, and focus on letting them have a few bites of their most favorite food, and if that puts a smile on their face and that brings them pleasure, that's the whole point of hospice. I think that family having a resource to turn to for questions about things like that, or when a family member or a loved one is closer to the end, is really a big part of hospice. And the patient may not be communicating anymore, they may be sleeping all the time, they may not be eating anymore, but at the same time the family still needs that support from the hospice personnel. The most important things to understand about hospice is that hospice is a mindset, it's not a place, and wherever that care is provided to keep that patient comfortable until the end, it really has to be centered around keeping that patient comfortable. So this can be done in the home setting most commonly. So about 90% of people that are Medicare beneficiaries say that they want to die at home, but really only about a third of patients actually do. And that's part of comfort, is dying at home. So I think that when it comes to home, we try to provide as much support to families when it's getting close, so that they have the medications that they need, they have the visits from the nurses that they they need from the aides, and they can get family together, or we can provide that extra help. If it's a patient who is in a nursing home or about to be in a nursing home or even in assisted living, then the same kind of care can be provided. Again, comfort is the goal. And that care could even be provided in the hospital setting if you have a patient who has very complex needs, if they're on a pain pump, if they're requiring medications really frequently that would be very difficult to do at home. Those are the kind of situations where they can get care in a hospital setting, or ideally in a hospice house like the hospice house we have here. I think patients deserve just as much love and care at the beginning of their life as at the end of their life, and I think that's what hospice can provide. And I'll tell you, the hospice nurses and the social workers and the aides and the chaplains, just can't say enough about them. They're an amazing team of people who are really providing patients comfort at the end of their life. And so patients can essentially decide how they want to die and in what condition and who they're surrounded by, and that's what hospice provides. So palliative care is also not a new concept, but more people are learning about it more recently, and I call it a fork in the road. And you may have patients that are actively getting chemotherapy or actively getting treatment for their heart disease, but they're tired and they're uncomfortable and they're in pain. And they want to continue treatment, they want to continue to fight, but at the same time they also want some relief from the symptoms that are really bothering them. And so palliative care are the experts that can help to balance that. And if a patient is at a point where they are thinking of stopping life-sustaining treatment, if they are thinking of stopping chemotherapy, or they are sick of being on all the medications that they're on, a palliative care expert can really help as far as putting into the spotlight their priorities in life. How can I spend more quality time with my family? How can I cut down on all these medications that honestly don't make me feel any better, actually make me feel worse? And how can I achieve the goals no matter how many days I have left that I want to do at the end of my life? And so palliative care is exactly that.
And do you all work together?
Yes, very much so. Palliative care and hospice is very hand in hand, and in a way you can think of palliative care as a step before hospice for some patients, but palliative care sees patients whose diseases do get cured, so they have cancers that are cured or heart disease that gets better. But if a patient is not responding to the treatment like we would hope that they would, then a palliative care physician may essentially hand off to a hospice team to provide that comfort that that patient deserves at the end of life.